And this program will be uploaded to our website probably early next week, and we'll let you know when that all happens. So I just want to introduce our lovely speaker today. We are so excited to have Patty Wild with us here today. Her presentation title is Hear Better, Think Better: Understanding Hearing Loss and Cognitive Health. So Patty is a recently retired audiologist with more than 4 decades of experience serving older adults. She trained at the University of Denver and worked for 18 years in a California community hospital rehabilitation center before spending 23 years at North Carolina Eye, Ear, Nose, and Throat Clinic in Durham. Throughout her career, she specialized in hearing testing, hearing aid fittings, and ongoing care focused on improving quality of life. So thank you so much, Patty, for sharing your expertise with us today.
Thank you. All right. So hello, everybody. I'm Patty Weil, and thank you for joining the Hear Better, Think Better program today. I'm in my home in Durham, North Carolina, and I welcome you from wherever you're listening in. Let's do the next slide, Shoshana. So I am an audiologist, a retired audiologist. And when I did my training back in the 80s, the clinical degree was a master's degree. In the late 1990s, early 2000s, along with physical therapy and pharmacy, they changed the clinical degree to a doctoral level degree. And now if you go to see an audiologist, most likely their degree will be an AUD or Doctor of Audiology degree. And that's not to be confused with a medical doctor, an ENT or otolaryngologist. Audiologists are trained in the diagnosis and treatment of hearing loss and balance disorders. And as Shoshana introduced me, I've spent most of my career working with adults, doing hearing testing and fitting hearing aids. Yep. So today we're going to talk about hearing in our brains. There's been so much discussion in the recent media about healthy aging, about keeping our brains healthy and preventing onset of dementia. I don't know if it's just because I've become a senior that I'm aware of all these articles and all this discussion, but I think it really has increased, and people are very focused on how to stay healthy as we age. So today we're going to talk about the way our ears work, what happens when hearing loss occurs, and what happens to our brain when hearing loss is untreated. And then at the end, we'll talk about what people can do and what options we have to seek help. And as Shoshana said, if you have questions, please put them in the chat. It can be about what we talk about today or any other questions that you might have. Starting with the basics of the way our ear works. The outer, middle, and inner ear are the three main parts of the ear, and then the brain, of course, is an essential piece at receiving the information. Our outer ear is the part we can see. It leads into the ear canal and captures sound waves. The vibrations then move the middle ear, which is our eardrum, which is a tiny, very strong but thin membrane about the size of a dime. 3 little bones are attached to that, and those all vibrate, and that energy is sent then to the inner ear. Our inner ear has the cochlea for hearing, and our vestibular system for balance is there as well. The cochlea is about the size of a large pea. It's very tiny. It has 3 little fluid-filled canals, and it's filled with thousands of tiny little hair cells that take the energy from vibration and turn it into an electrical or nerve signal. That signal then goes up the auditory nerve to the brain, where the auditory cortex sits inside the temporal lobe of the brain on both sides of our head. So we have we have input from both our right and left sides. The next slide shows the anatomy of the ear. Again, the outer ear leading to the eardrum. Problems in that area most commonly can be wax buildup. A lot of people worry that they have wax buildup affecting their hearing, and honestly, most of the time they do not. I mean, it certainly can happen, but many times people would see me in the clinic and say, I can't hear, I need my ears cleaned. And unfortunately, that usually wasn't the reason they weren't hearing well. But any problem in the outer ear or in the middle ear can be impacted by a hole in the eardrum, from illness or rupture, from injuries, or fluid building up behind the eardrum. And those are all problems that cause a dampening of sound, and that's called a conductive hearing loss. Usually medical treatment or intervention can correct those. When hearing problems occur on the inner ear, and that's that purple kind of snail shell structure, that's where the nerve of hearing lies, and loss of sensitivity there is called a sensory neural hearing loss and is generally not medically repairable, at least at this stage in current medicine. If you have both a sensory neural hearing loss and a conductive hearing loss, that would be called a mixed hearing loss. So hearing loss occurs usually from several causes, and as we get older, there's usually a combination of reasons why hearing loss occurs, aging being the biggest reason. Noise exposure can be prolonged noise exposure, for instance, working in a factory or using power tools. Sudden exposure to very, very loud sounds can result in acoustic trauma, and that would be something like being around a firecracker or a gunshot. Generally, noise exposure is a cumulative effect, and noise that we're around in our younger years before we know better often shows up decades later as a hearing loss. Hearing loss from noise exposure is pretty specifically located in the highest pitches. When we do hearing tests of low, middle, and high pitches, classic noise exposure hearing loss takes out the high pitch sounds. There are a number of illnesses, injuries, and infections that can be related to hearing loss. Not so much recently, but maybe as vaccines are waning. Mumps was often a cause of one-sided hearing loss, and measles used to cause deafness. Hopefully we won't see that increase. Genetic factors, family history are other considerations. There are families where hearing loss seems to run in them. Next slide. But the biggest factor is aging. And while 15% of the US population might have hearing loss, the numbers as we get into our senior years go up very significantly. And not only do the number of people with hearing loss increase with aging, but also the degree of hearing loss. So when we look at hearing loss across low, middle, and high pitches, we're looking at whether hearing is normal, within the range of normal, or if there's a mild loss, a moderate loss, a severe loss, or a profound loss. A profound loss would be very little response to sound or deafness. So in younger years, generally losses will be milder, and as the numbers are going up, there's an increase in moderate or severe loss. Loss to the point that hearing regular conversation can get difficult when somebody is not using assistance, not using hearing aids. So I'm in the senior group at the age of 68, and my most recent hearing test was normal with the exception of the highest pitch, which was a mild loss. But even my response to sounds in the normal range are not as good as they were 40 years ago. So my hearing is not quite as acute as it used to be, but it's still generally normal for conversation level speech. So we see a change in hearing, a less sensitivity, and increasing degree of hearing loss with age. So next slide, please. Shoshani, yeah, there we go. So whether we have hearing loss or not, another thing that's happening as we get older is our speech processing is getting slower. Our brain needs more time to process information. I think this is a really important point to make because I've had a lot of people, and when I was working in clinic, people would come in around age 50, 55, and they would say to me, I'm having a lot of trouble hearing. And I would test their hearing, and it was normal. So then I would have to have the discussion about your hearing's pretty good, or there's very minimal loss, but what you're seeing is a change in your speech processing. So if somebody says something to me and I say, now, what did you say? Before they repeat what they've said, often I've got it. It just took me that extra bit of processing time to figure it out, to decode what they had said. There's lots of factors that can make that more difficult, and we'll talk about that in a second. But I think having an awareness that it's not just a matter of our ability to hear tones, it's also how well our brain can participate in processing what we're hearing and ignoring what we're not interested in hearing. And it's important whether someone has hearing loss or not to keep this in mind when we're talking to somebody who's older. So on the next slide, we can talk about what do we do when our speech processing is a bit slower, or we're trying to talk to somebody who we assume by their age has slower processing. And these are all, I think, suggestions and tips that are good for communication for all of us, but become really important when we're talking to an older person. So I say to my husband all the time, I can't hear you if I can't see you. And this is, again, with pretty normal hearing. I need to be able to focus on his face to get the message coming right at me rather than talking to him from another room or from, with his head in the refrigerator asking me something. When possible, we want to reduce background noise. We want to be able to have good lighting, see the person we're talking to. It helps to slow down. I tell this to younger people all the time. If you would just slow down, I think I could catch what you're saying rather than trying to keep up. Often they're talking about things that have different vocabulary or different references. So I really need more redundancy. I need to try to figure out, again, decoding what they're saying. When somebody's not understanding you, rather than repeating it or repeating it louder, maybe rephrase it or try to figure out what piece they're not catching. And that can be hard with proper names, with words that we don't have a lot of automatic understanding of. So this is a point that's not so much related to hearing, it's much more related to how our brain's working. But I think it's really important. Even when somebody is well fit with hearing aids, slower processing is going to be a big factor in how easily they're understanding and how difficult it is for them, and especially in more noisy situations. And I just want to go back to that point one more time. The other thing that happened is I noticed during COVID, a lot of people came in and said, I've just started having trouble hearing. And it was wearing masks. They realized that they were missing the visual, being able to see the person's face. And they said, well, I can't lip read, but I can't hear when someone has a mask on. So we all passively lip read and speech read. We get emotions when we can see people's faces. So I think that's a really important point with our processing, and the way we take in communication is not just with our hearing, but we really look at the person and body language and all of those things. So let's talk a little bit about cognition, about cognitive decline. You can go back one slide, Shoshana, the one with the, yep, let's stop there for a sec. So with normal aging, and this is certainly something I'm noticing myself, is we all have some senior moments, some times of just having a word on the tip of our tongue or trying to remember the name of an actor in a movie that we're talking about. These can be frustrating. Our thinking and memory can be working a little slower than we're used to. I think it's frustrating and sometimes a little anxiety producing because we don't know if it's the beginning of something um, of future decline. So that with normal aging, just like our processing can get slower, our thinking and memory can get a little slower or have little blips at times. The next stage would be mild cognitive impairment or MCI. And this is when that the memory lapses or the thinking slowing can get more noticeable to the individual or maybe to people around them. It's a little bit more than you would expect with normal aging. People are often still independent and and their daily life is largely unaffected, but they may be needing support for financial tasks or for major life decisions. The thing about mild cognitive impairment is sometimes it's an early or first stage of dementia, and other times it's an indication that something's going on in the body and in the person's life that can be changed and modified. So, um, if there are factors like an untreated urinary tract infection. I remember in my mother's later life, she had a very bad urinary tract infection, and it caused some cognitive changes and health changes that were very dramatic. And when that was diagnosed and treated, she came back to herself in a way. So the treating the underlying problem cured that for her. There can be other things like medications that are not working well together or untreated hypertension or poor eating, somebody who's very sedentary, and sometimes making healthful changes will reverse the issue. And this is at a time when often people go to their primary care doctor or their internist with a concern about cognitive issues, and sometimes some um, sleuthing around can sort out issues that can improve them, vitamin deficiency, things like that. When cognitive impairment is not caused by something that's able to be adjusted or reversed, it may in fact be an early stage of dementia. Dementia is when thinking and memory issues are significantly affecting the person's daily life. Dementia requires a diagnosis, and often primary care will refer on to neurology for that diagnosis, and cognitive testing, blood work, scans can all be done to try to further understand what's going on with someone. The initial symptoms can sometimes relate to the type of dementia. So Alzheimer's, which has more than 60% of cases are diagnosed as Alzheimer's, often the early symptoms are short-term memory loss, where other issues, vascular or Lewy body or frontal temporal dementia, often have early symptoms of attention, planning, reasoning, sort of a different picture to them. So let's talk about risk factors for dementia. There are ones that are modifiable and non-modifiable. So hearing loss is certainly one of the largest modifiable risk factors. It's something that can be treated, usually with hearing aids, but there are others that are modifiable. Our non-modifiable ones, if we look at things that we can't do anything about, it's being of a certain age. We can't change our advanced age, which is a common connection to dementia. The other things we can't change are our genetics, our family history, our sex. Women are more likely to be diagnosed with dementia, or our ethnicity. Some ethnic groups have a higher percentage of persons with dementia than others. So these are things that are fixed, modifiable risk factors, and these are things we do hear a lot about in current media, are things like going from being sedentary to having regular exercise, regular movement, managing health conditions such as managing hypertension, managing diabetes well, not smoking, using your seatbelt in the car and a helmet when you're bike riding to prevent a traumatic brain injury. And then social activity, very, very hot topic about how being socially engaged and active is a huge benefit to reducing the chance of cognitive decline. So again, within all the risk factors that are there for our brains aging well or not well, some we can modify, some we can't. Hearing loss is one of the ones that we can make an effect on by changing how well we're hearing and how well that will keep us socially engaged. Let's go to the next slide and talk about how hearing loss affects our brain, affects our cognition. So one of the things that happens when we're not hearing well is that our brain is working extra hard and with a lot of effort to try to understand what's happening. This is called cognitive load. Shoshana, if you do the next slide, we'll come back to this one, but if you put the next slide on, trying to read that paragraph on the right side, you probably could figure it out, but it would take a lot of effort. You'd be solving a puzzle, basically. But if we look to the paragraph on the left side of the screen, it's clear, it's easy to read, takes very little effort. This is a visual example of what can happen in our brain when we're trying to hear, when our hearing system either doesn't have the volume, doesn't have the clarity, sound is coming in distorted, and it can be really frustrating. So let's go back to the slide before that. And so that's our example of what's happening in the brain when that effort is being required to decode sound in the environment. It's taking away energy that could be used for building memory, for processing other information. And then to the right of that, social isolation and depression, I think, are kind of siblings a little bit. They are both connected to cognitive decline. And they also both can be kind of outcomes of not hearing well. When going somewhere socially becomes so frustrating, somebody says, well, I just don't get anything out of it anymore. They might stop going to religious services or friend gatherings. That's a difficulty. And then depression can either result from being withdrawn socially, or it can be a condition of its own. And I think those two are really markers that kind of work together. And then physically in the body, there's studies that show that not hearing well, not stimulating the part of the auditory cortex that responds to sound, leaves that part of the brain a little bit atrophied. It's sort of like using a muscle, use it or lose it. And not having that stimulation is not good for that part of the brain. There are a number of things that, like social isolation and depression, can both be connected to hearing loss and to cognitive decline. So factors like cardiovascular disease, smoking, diabetes can be factors that can affect both things. The studies, let's get that one. The studies that are being done are pretty new. We really need long-term studies, and there's a bit of an ethical dilemma in designing a study about hearing loss and cognition, because if you have two groups that both have hearing loss, and you fit one group with hearing aids and one group you don't fit, and then you see what happens with their cognition, it's sort of a little bit unethical to leave that one group unaided, as it were, because you're trying to do this science, but then the people aren't getting the benefits of hearing aids in their daily lives. The other piece that's a little difficult is relying on the study members to report how much they're wearing their hearing aids. So I will say that most modern hearing aids have, in their computer chips, they have a way to record hours of wear time. And I found that very helpful when I worked with clients in fitting hearing aids. But in a study, it's a little difficult to know if people are doing what they say they're doing, even if you're checking behind them with the technology to see how many hours hearing aids were worn. So studies need to be done. We need more of them, and we need longer term studies. A lot of the information in the that's out in scientific journals now is really preliminary. Okay, we're going to skip that one. So sooner is better than later as far as treating hearing loss or almost any of these factors related to dementia. We want to keep the brain engaged and healthy from a younger age. If hearing loss is diagnosed, your brain will never be any younger than it is today. And a more plastic brain, a younger brain, is going to adapt to amplification. If that's the course of treatment, it's going to be better to get it sooner than waiting until the loss is more difficult and you've been more unaware of sounds in your environment. There's a lot of technology that's available with current hearing aids, and using them with other technology, with your smartphone, having a transmitter for Bluetooth for your television. All of those things I think are easier to adapt to when you're more engaged with technology. We want to protect our cognition, keep our brain healthy, and we want to stay socially connected. So there isn't any benefit to waiting once hearing loss is identified to the point where hearing aids may be helpful. So we could talk about hearing aids a lot, and in order to get to that point, you need to have your hearing tested. Some primary care offices do hearing screenings. I've also seen that Costco or some hearing aid dealers often offer free screenings. Sometimes health fairs do. And a hearing screening is fine. It's a good place to start. If your hearing test is normal, I think you're okay. But if there's any amount of loss that's shown on a screening test, then I think it's time to see an audiologist. That certainly is my bias. An audiologist is the professional who is best trained and is the right person to be able to do a reliable professional test and then explain the results of that test to you. You can self-refer to an audiologist. Often getting a referral from your primary care ensures that Medicare, if you're of that age, will cover it. But you don't have to see a physician if you go to a practice where audiologists and ENTs are in the same outpatient practice. Often people will want to see the ENT, especially for that initial visit. They'll want to be cleared by the doctor, make sure there's nothing medical that couldn't be done or changed, rule out wax as a factor. Some people have allergy issues or other problems that they want to make sure are not contributing to any level of hearing loss. But if you see an ENT or see your primary care doctor and hearing loss is pretty straightforward as the concern, you can see an audiologist for testing and then get recommendations from them about what's next. If loss is very mild, they'll recommend you return in 1 to 2 years for follow-up. If loss is present, they'll talk to you about hearing aids or set a time to talk to you about hearing aids and give you your options there. When we talk about options, we're usually talking about prices and levels of technology and whether assistive technology would be warranted. So in my opinion, hearing aids, well, the technology in hearing aids is amazing. It's become a long way and it's better than it's ever been. But what people will often say to me is, I don't need a lot of extras. I just want to hear better. I don't need a lot of bells and whistles. And that's actually not the case with hearing aid technology. There aren't features you won't need, but what you will get is a better computer chip, a better technology in the hearing aid to let you hear better in difficult or noisy environments. So hearing aids at most basic, mid-range, or advanced price points will all do well in a quieter setting, one-on-one. But as hearing technology gets better, it's going to give you a better chance when you're not in an easy or quiet setting, when you're in a restaurant, when you're in a reverberant space like a museum or a shopping center, when you've got lots of different noise sources, especially other voices coming at you. Better technology hearing aids um, will do a better job at keeping you engaged and hearing the things that you want to hear. Uh, in a private audiology practice or an ENT practice with audiologists, hearing aids are probably more expensive than if you consider a big box retailer. I think if you're at a private hearing aid dealer, prices are about the same as they would be with an ENT practice or an audiology private practice. If we're considering price point as our biggest motivator, then the big box stores certainly have the lowest prices. But I want to talk about when you're faced with decisions about your hearing and what should be done next as far as considering hearing aids. I think you have to, and everybody's different, everybody's an individual in this way. You have to look at your abilities, your budget, your priorities. Sometimes when I would sit down with people, they would say, I want the best there is. I want to hear as well as I possibly can. I need the very best technology. Other people, same hearing loss, might say, I don't want the very best, most expensive one, but I don't want the most basic one. I want the one right in the middle. Neither of those statements had anything to do with what the hearing aid could do. It was really just their comfort level in how they made purchasing decisions. So I think it's important to kind of look at what your own priorities are, but also listen to the advice that you're given from your audiologist, maybe talk to other friends and family. And I would sometimes have clients come in and one spouse would be like, this is good enough for me. And the other spouse was like, spend the money, get what you need, get the best thing. And we're talking about often for folks, we're talking about a significant amount of money when they're considering hearing aid purchase. When you get your hearing tested, you can check with your insurance. Medicare does not help with the cost of hearing aids, but some plans that are supplements to Medicare may offer a discount program or a benefit program. Occasionally, there are Medicare supplements that have hearing aid benefits. It's something that really has to be looked into, and the person that you're working with may help you with that, but you should really know what your coverage is when you go in. Often the plans that offer a benefit will also state you have to get a hearing aid of a certain level, generally one level down from a top of the line hearing aid. Still a good technology, but it may not offer you the best technology. So you want to know what your plan is if you have any coverage. And if you do not, then you're really, then the price point becomes a big factor. Some people are very comfortable with technology and they don't need a lot of support. They feel like they can get a hearing aid from a hearing aid dealer or from a Costco and manage it themselves pretty well. Other people know themselves and they know they're going to want somebody that they can go to for adjustments, for support, for follow-up as they get used to wearing that hearing aid, or for care as they go on with their hearing aid needs. Again, the big box retailers have very low price points, but they are limited to fitting people with pretty straightforward hearing losses. So the loss should be no more than moderate, mild to moderate. It should be a hearing loss that doesn't involve a lot of medical issues. They're not for children or for somebody who really needs a lot of support in keeping the hearing aid working well and in understanding how to use it. Hearing aids can be sold online. And my biggest concern with that is when you get that hearing aid, is it programmed properly for you? Do you need adjustments and do you need follow-up care? And if you do, you're kind of on your own or having to deal with that online a provider having to mail it in if you have any problems. I just don't think the level of care is a good idea with an online hearing aid sale. Um, we're going to talk more about over-the-counter devices, but Shoshana, if you could go to the next slide. This is a photo of one line of hearing aid products. The ones that say receiver in the canal is what I often see people wearing. I don't often see them wearing blue or green hearing aids, but I'm all for it. But a small hearing aid that goes behind your ear with a wire going to a speaker in that little clear looking dome at the tip of it is pretty standard for current hearing aid technology. That's often what people are getting if they're at a big box store or working with a hearing aid dealer or audiologist. To the right of those, behind the ear hearing aids are a bit, they look bigger, beefier. Those are often worn with a custom made earpiece. And those are nowadays, those are generally used for folks with more severe hearing loss, where the open small wire is not always the best fitting. Those look a lot like what hearing aids used to look like 30, 40 years ago. Below that line are all the ones, hearing aids that are custom made, and they're made from a mold of someone's ear. They're custom made only for that individual. There's generally not a benefit to wearing a custom hearing aid versus a behind the ear. They often can both do the same job. But I would say that while often people ask for the very, very small in the canal custom hearing aids, and they want them to be less visible, the downside to that is when you feel something very snug in your ear canal, your own voice is going to be very resonant. You have to overcome the fact that you're feeling very plugged up. So a lot of people come in and ask for that type of hearing aid, and it may not be the best one for their hearing loss or for their anatomy. Their ears may be too small, and there isn't any advantage to having the little one other than cosmetic, where with a hearing aid that's worn on the back of the ear, you often have more space for two microphones that can offer better foreground and reduce background noise, better hearing from the front with reducing background noise from the back. So generally, and I think it's true with almost all younger audiologists, they're going to stay away from the custom hearing aids unless the client insists, and they're going to stick with the behind the ear or the receiver in the canal style. Hearing aids are generally matched to hair or skin color. Sometimes you'll see brighter colors, but I didn't have very many people go for that. There's still, unfortunately, a bit of a stigma with hearing aids that we don't have with glasses. People wear very fashionable glasses, and I'm hoping that trend will carry over eventually to hearing aids. The next slide, Shoshana, again shows styles of hearing aids from different manufacturers. These are all companies that I have worked with, or I have had worked with over my years as an audiologist. They're all good companies. Generally, audiologists work with about a half a dozen to a dozen major manufacturers, and hearing aid dealers, standalone franchise hearing aid dealers, are places like Beltone or Miracle Ear or Hearing Life. They may work with just one or two companies, usually one company as a franchisee. The hearing aid industry is small. They all share in a lot of circuits and microphones, so often they are not that different. They all have equally good quality, but the person you work with will probably have a relationship with one or two or three of these companies and get the best customer service and stay up to date with their particular changes as hearing aid models progress. And they are always progressing. They're in a continual improvement cycle. But when you are ready for hearing aids, you kind of have to jump in with what's there. There isn't any point in waiting for something better to come out, because something always will be coming out that's going to continue to get better. When you can, let's go back, Shoshana. We want to go back 2 more slides to the One more. Yep, right there. What I also would say when we're talking about costs of hearing aids, and premium hearing aids for a pair can be around $6,000. Moderate, mid-level hearing aids maybe 4,000 or 5,000, and basic level 2,000 or 3,000 a pair. When we think about that cost, it's pretty significant. And where I just spent a lot of money, I had cataract surgery this year. I spent a lot of money getting a multifocal fancy lens, but it was a one-time cost. Hearing aids generally are replaced every 5 to 7 years. Technology changes. It's a device that has wear and tear from humidity, from being on our bodies, from being touched. There's often, almost all the time nowadays, the batteries are internal and they're rechargeable, and those have a certain lifetime. So it's a factor that when we look at hearing aids and what we're fit with, we want to consider the purchase, but also realize it may not be a once in a lifetime purchase. If there are specific questions about hearing aids that I haven't covered, please, again, put them in the chat. We'll get to them at the end. But I want to spend a minute talking about over-the-counter devices. So hearing aids were classified as medical devices, but in 2022, that was lifted, and the FDA made it so that other companies could get involved. And for adults with no more than mild to moderate hearing losses, they could produce a hearing device. They don't call them hearing aids, but they call them hearing devices. And the idea was to open up the market to people who may not have gone that medical route of getting medically cleared for hearing aids, who maybe don't live near a medical center, who were younger and wanted technology that they could be in charge of. So all these factors to open up the market and allow access was a part of making that change. And the idea was to have less expensive devices that didn't have the whole support of a big hearing aid company behind them. The limitations are that you have to manage your own fitting. You have to make your decisions. You have to work with the company that you purchase them from, either online or in a discount store, to buy the equipment. Often when they started out, they were really amplifiers. They didn't have a lot of advanced technology in them to manage background noise, but they were very inexpensive. And it's difficult to know what you're getting if you don't have a professional helping you to sort through that. I don't have a lot of experience with over-the-counter devices because I couldn't work on them. If somebody came to me with something they bought online, it wouldn't be software that I could work with. If somebody buys hearing aids at Costco, they couldn't bring them into me as an audiologist and ask me to help them with them. So the over-the-counter devices were I think they're a good idea. I think they help to stimulate the market. They get people in that might not other come to hearing aid fittings, but they have their limitations. I'm starting to see now, since we've had more years of over-the-counter devices being available, that there are some devices that sell more in the $500 to $1,000 range that have rechargers that can be used with Bluetooth technology. So they're getting closer to looking like hearing aids, but again, they're relying on the consumer, to be a very active part of the fitting. And again, it's mild to moderate losses, not for somebody with a very significant hearing loss or that needs generally anything more than a straightforward kind of vanilla fitting. Often with hearing aids and sometimes with over-the-counter devices, accessories can also be useful. And for this, I'm thinking of connections to Bluetooth via a cell phone. You can have a television transmitter that sends the sound of the television right into your hearing aids. You can hear your cell phone through your hearing aids. Listen to audiobooks if you're out walking. There are partner mics, so you can give your spouse a mic that they can wear in a restaurant or driving in the car that sends the sound into your hearing aids. There are devices that you can put on a table when you're in a group to try to help you stay engaged and hear in that group. So for more significant hearing losses, sometimes just the hearing aid is, well, it can be very helpful. It may not be enough. And adding accessories, it's another added expense, but adding accessories can bring in improvement in some situations that remain difficult, even though you've got hearing aids. Hearing aids only help you if you wear them. I have patients who say to me, yeah, I put them on when I go out, but I don't need them at home. This sort of circles back to the studies on our brains and our auditory cortex and how important it is to keep stimulating our inner ear. We know people are at falls risk when they have a hearing loss. They may not hear their body in space, if that makes sense. You're hearing their footsteps. Getting hearing aids, I tell people to put them on in the morning and wear them all day. It isn't, I think it's not great if you're deciding, do I need them now and do I need them now? Because if you're taking them off, you may need them and they're not in your ears. You're not getting used to the feel of them. You're not getting used to the way ambient sounds are in your home or social environments. And people do best and get the most out of their hearing aids when they wear them regularly and consistently. So hearing aids and over-the-counter devices are almost always sold with a minimum of a 30-day trial. If you're on the fence, I say use that trial period and wear the hearing aids all day, every day. Even with a very mild loss, I think it's important to reestablish your sound environment at a better, more normal level and to adjust from there. Usually, if we do anything for consistently for 3 weeks, we form a habit, and I think we'll know whether we're getting benefit from hearing aids. It's also important to ask the people around us when we try hearing aids, how do you think I'm doing? Are you seeing any change, any improvement? So if we go, let's do that last slide and then we'll get to questions. So hearing loss is more than just an inconvenience. It affects how our brain functions. Not treating hearing loss is a significant and modifiable risk factor for cognitive decline. There are strategies that help everyone, especially when our speech processing is slower with older people and people with hearing loss. The earlier we get an evaluation and follow up on those evaluations regularly until possibly treatment is needed will lead to better long-term outcomes. And over-the-counter devices are interesting. They're still in their very early days, and they may be helpful for some people. I personally feel that professional guidance is still really valuable.
Wonderful. Thank you so much, Patty. There are a number of questions in the chat, which I can go ahead and read out. Let me start with this one. So someone said they actually had a hearing test yesterday. I missed hearing 2 words out of 20. Says my ACPTA on the right ear was 26.2 and on the left 31.2. They recommended a hearing aid. What do you think? They are pushing an Oticon Intent 1. It's one of these free places with just a technician and not a proper audiologist. My insurance doesn't cover a proper audiologist, but I'd like your second opinion.
So that's a very specific question. It sounds like a mild hearing loss. And given everything I've said today, I think that treating a mild hearing loss is really helpful, and it's important to get started with technology as soon as you're ready. I'm kind of curious what sent you in for that testing. Was it because of concern, or was it for just a routine thinking it would be a baseline testing? I know that model hearing aid. It's a very good hearing aid. It's a premium and expensive hearing aid, but a very, very good technology. Missing a couple of words on a word list test isn't it's an indicator. It sort of shows there's a trend that maybe we're missing something at average conversation level, but it doesn't. It's not. It's still a pretty good score. So it's a little bit hard to say. I think um, you have to get back to where that fits in for you, whether that fits in your budget, whether you're ready to consider hearing aids, and perhaps using a trial period is the best thing to do to be fit with the hearing aids and see how you do in your daily life and how your family supports you on that.
Thank you. Somebody also asked, how often should we get hearing tested? Is it at a certain age we should start this testing versus just on an as-needed basis versus being proactive?
Okay, so you should have your hearing tested as soon as you or the people around you tell you you need to have your hearing tested. My two adult daughters tell me all the time that I can't hear at all, and I can come back to them and say, well, actually I have normal hearing almost. And it's a good retort. It doesn't get at the point they're probably talking about my processing or my attention. But I think if you haven't had a hearing test by your 60s, certainly by the time you get Medicare at 65 is a good time to request a hearing test. Medicare covers a hearing test. That's where having a doctor's referral is important, and it may be the difference between a test being covered or not covered. But generally, insurance will cover diagnostic testing, and everybody should check their benefits. But I think having a hearing test, if you don't suspect anything, have one by the time you're 65. If you've had concerns about your hearing, I would certainly go get it tested. If everything's in the normal range or very close to normal, usually I tell people come back in a year or two. And if hearing loss is diagnosed and somebody is not ready to consider hearing aids, then I have them come back in 1 year. Um, Once you're fit with hearing aids, hearing tests are generally done when we're going to make a change in the hearing aid programming. If you feel you're not doing well or you're struggling more, having a hearing test and then reprogramming the hearing aid to that new test, it can be done. And so hearing tests are generally done every 2 to 3 years if things are pretty stable.
Okay. A couple people asked about, I never know if it's pronounced tinnitus or tinnitus or either one, but a couple people asked how tinnitus fits into this hearing loss picture.
Right. Right. So I didn't talk about tinnitus. Tinnitus can come from many, many sources. It's sort of a symptom of some issues, and it can also be its own thing. I say tinnitus. I think more current is tinnitus, and both are correct. And tinnitus is a noise in your head or in your ears that you're not making. It's not coming from the external environment, but it's coming from inside your head. We don't really know what it is or what causes it, but our theory is that those little tiny hair cells in the inner ear, most of the time, if there's some damage to hearing, it causes some firing of the space where those hair cells used to be working well. We often can match the tone of tinnitus to the place where the hearing loss exists or exists at its worst. So it can be a ringing, a roaring, a steady state sound, a pulsing sound that can vary a lot. Some people have it come occasionally. Some people have it constantly. For some people, they live with it without problem. And there can be people that are really kind of driven kind of crazy by tinnitus. It can be a really big issue. Duke has a program for tinnitus. They have an audiologist that specializes in tinnitus, and they'll do a battery of testing. They'll try to match the tinnitus. They might work with biofeedback or background noises or apps on phones or computers to try to help people manage tinnitus. So it's a pretty big deal, and it's often one of the first reasons that people come into the ENT to be seen. I often have people come in complaining of ringing or noises in their ears, and they don't recognize the fact they have a hearing loss. If they have a hearing loss and it's significant enough to be treated, the good news is that treating the hearing loss with a hearing aid often helps them to be distracted from and get some relief from their tinnitus. So when I had patients who needed hearing aids that also had tinnitus, about 75% of the time, wearing their hearing aids consistently help them to be less bothered by it, or to notice their own tinnitus much less. There was about 20 years ago, hearing aids were equipped or had a circuit in them as part of them that was a tinnitus masker. And so besides having the hearing aid help improve the sounds, the volume, the tones that you needed, you could additionally have the option of including in a sound. It might be a customized noise, it might be sort of a white noise. And the theory wasn't so much that you were going to overlay your own sound with this other sound through the hearing aid. It was more that you had a sound that you were then in control of. And a lot of the things that drives people crazy about tinnitus is they can't stop it. It's inside their body and they can't alter it or stop it. So having a little sound in the hearing aid gave them something they could control. I had one client who would like to read in quiet. She would hear her own tinnitus. It would drive her bonkers. So she would turn on this little bit of, it could be a steady static. It could be sort of an environmental ocean sound. And listening to that was preferable to her than just hearing her own tinnitus. I have to say that of all the many patients I fit, I only had a few, maybe a dozen or less, that really found the tinnitus masking feature in their hearing aid to be something that they used regularly and found to be helpful. So it's not a big part of what hearing aid products are pushing nowadays. It was sort of had its moment, but if somebody's very concerned about that, there are things that that can be done with hearing aids. If you have a hearing loss, if you have tinnitus and your hearing is still normal, then you might be looking at talking to the ENT about it or neurology about it. And it can, again, come from a number of sources, not always, but typically hearing loss is the main reason people have tinnitus, but it can be related to other problems.
Hmm. Thank you. Yeah, that's good to know that's an option at least to have sort of that secondary noise feature on
Mm-hmm.
the hearing aid. A couple people asked or talked about cochlear implants. So one person said older adults are being offered cochlear implants these days. Do you know what the process of relearning to hear looks like for an older adult? And then somebody mentioned that Medicare will pay for cochlear implants with significant hearing loss per
Right,
audiologist evaluation.
right. So I never worked with cochlear implants. It was never a scope of my practice. And I didn't work in practices where cochlear implants were being done. I did have clients who had severe hearing loss, and it got to the point where their hearing aids were providing less and less benefit. Especially, I had a couple young people in their 40s, and referred them on to either Duke or UNC, or there's a private practice in Raleigh that do a lot of cochlear implants. And I saw the tremendous benefit they got. Cochlear implants, I think, are covered now by Medicare, but it has to be, you have to have severe hearing loss in both ears. I don't think they're covering them for a single-sided or unilateral hearing loss. But just like hearing aid technology has improved tremendously, cochlear implant technology has improved. You can get interfaces with smartphones and, of course, rechargeability and assistive devices. And I did have some elderly clients, people over 60 and 70, even 80, that got cochlear implants and felt it was worthwhile, felt that the benefit they got was significant. I think that in the Durham area, Duke has a program. You can go in for an evaluation and they look at your insurance coverage. They look at any other factors that might limit you health-wise from having that surgery or from benefiting from a cochlear implant. And you can hear from them more, not whether you're a good candidate. As the technologies improve, they've opened up candidacy. So some people can have part of their hearing be pretty intact. It's usually the lower or bass tones, but they can lose all high-pitched sounds. There are cochlear implant technologies now that can give you the high tones through the cochlear implant and still preserve, you can still preserve some of your hearing that's still pretty good. And usually that's the lower pitch sounds. So there's been a tremendous amount of work in that field, tremendous amount of improvement. I'm not an expert in cochlear implants,
Thank
but
you.
we do have those resources in this area.
Yeah, it's good to know and good to know where in this area to look too, if that is of interest or need. Could you speak to balance problems as it relates to hearing problems?
So the balance system, the vestibular system, and the cochlea, the inner ear, are in the same little bit of our temporal lobe of our brain. And they sometimes influence each other and they sometimes have individual issues. We have lots of folks with hearing loss that have no issues with balance, and we have some people that have significant balance problems that still have very good hearing. So that it's not a one-on-one problem. Each one is its own system. Often what I see in people getting older is balance as a problem with someone who's deconditioned or not physically active. The other thing very common is something called BPPV, which is benign positional paroxysmal vertigo. And that's when people talk about the crystals being off in your inner ear. You can get some sudden vertigo, which is a spinning sensation. You can feel like you usually feel like the room is spinning, and it can come out of nowhere. There are maneuvers that audiologists can do, ear, nose, and throat doctors can do, physical therapists can do, that can kind of reposition those little crystals in the balance system and put them back where they are so they won't be causing that irritation and resulting in the vertigo symptoms. Sometimes that balance problems, vertigo, again, is related to a viral labyrinthitis, a viral illness that can come out of nowhere and hit you really hard and gradually go away, may never to recur again. The BPPV, which is that, again, the crystals in the inner ear, if you've ever had that, it can happen again. You can be sort of prone to it, and people can learn exercises to do at home. Working by staying physically active and I think that helps a lot with balance issues with aging, but the balance system itself has to be sorted out from other overall health issues and overall health concerns. So ENT doctors and audiologists help with balance issues. There are audiologists that specialize in the testing of that. There's a really good one at Duke. But I think it like tinnitus is something that you have to kind of sort out where it might be coming from, because there can be other issues like blood pressure that can result in dizziness that are unrelated to the ear.
Okay. I have done, I think, some of those maneuvers, the Epley maneuver, or whatever it's called, with the ear crystals. Perhaps many of us have had experience with that.
Yeah, when it works, it's a magic cure. It's amazing. You can look it up online. There's a lot of information on the internet.
Yeah, it's one of those things that sounds like this is science, but it is. They're crystals in the ear. All right, this is a comment. So I chose Costco over Duke because the ongoing maintenance was much easier and user-friendly. I had to have an appointment for Duke for any issue. With Costco, I can walk and talk to someone, which I have done frequently. So that's just sort of a push for Costco.
I have had a lot of folks do very well at Costco. I don't can't argue with their pricing. What I do say about Costco is get the very best technology they offer. Often the prices aren't that different and they're pretty affordable. So I would, if you're going into Costco, yes, you can do walk-ins. You're probably working with a hearing aid dealer and not an audiologist. You might work with an audiologist, but usually it's a hearing aid dealer. Some are better than others. I've seen a lot of people that got their first set of hearing aids at Costco and then came to us when they were ready for something, for their second set, for something where they were having more difficulty, wanted something that would work maybe a little better. and wanted the professional um, support of an audiologist. But
Hmm.
um, I don't think there's anything wrong with going to Costco. I think there are some limitations when you go there, and if you're aware of them and that works fine for you, I think um, that's okay.
Somebody asked, should one, you may have spoken to this earlier when you said, get tested at 65. But someone said, should one get a baseline hearing test? And if yes, at what age or when?
Yeah, I mean, I think that having your hearing checked, having regular eye exams, having our teeth checked, having our ears checked, hearing often sort of gets thrown off that list of having regular checkups. So I think you can ask your primary care doctor at any time if they're not suggesting it. I used to see people sometimes come in and they would have had screenings at primary care, but it wasn't very common. Um, I don't think my doctor ever asked me to have my hearing tested. I mean, I would sometimes get it tested at work or test myself, which is something people say you can't do, but I think I could. In any case, you know, anytime I think most of the time when people come for a hearing test, it's because they're having something going on. They're having an ear infection, they're dealing with significant allergies that are affecting their ears and their hearing. Um, I think we sort of feel like everything's okay until it isn't. But there's nothing wrong with getting a hearing test and having that serve as a baseline. I used to love it when I would have clients come in and I would look back through their medical record and find a test from 30 years ago. So at 50, maybe would be a good place to start, definitely by 60, and absolutely by age 65 would be what I would suggest. And that's
Hmm.
if you're doing well. If you're having any questions or concerns, if one ear hears better than the other, when you go to your primary care, you can, and they quickly look in your ears, you can say to them, how does it look? Is there any wax buildup? Anything I should be worried about? So I think it's okay to advocate for yourself, especially as we know how important hearing is for our cognitive health. I think it's okay to ask for those things.
Hmm. Um, Speaking of the one-sidedness, someone asked, can you speak to single-sided deafness issues?
Yeah. So we need two ears in order to localize where sounds are. And when we lose hearing on one side, or when hearing is different on one side, it can really be a problem. It throws us off. So when there's a sound in the environment, we look toward where we hear that. And when we hear better out of one side, we have to then replace our two ears working together with visual of trying to figure out where the sound is coming from. Um, it puts us at a disadvantage in background noise, and it makes hearing, especially from the side with the hearing loss, more difficult. We have a head shadow effect, and we lose a little bit of volume when sound is on the side where there's a hearing loss. Often people's hearing was not even when I would do hearing tests. Generally, it was fairly symmetrical with a typical hearing loss caused by getting older. But often people had a lot of issues that something had happened to one ear. They'd had surgery on one ear. So hearing unevenly is not unusual, and hearing aids can account for that. But when somebody loses hearing in one side, it's really really puts you at a disadvantage, and it means that you then have to compensate for it by the way you position yourself. By when you're going for a walk with your friend, you got to put them on your good side. So it causes more issues with hearing, especially hearing and noise, and it causes you to kind of have to ask people to manage that issue for you. Hearing aids often can be fit to a single-sided hearing loss, but when the loss is complete, or when the amount of distortion in the hearing loss is so great that it doesn't help, um, then sometimes a hearing aid on that bad side might not be recommended. There is something called a cross or bicross hearing aid, and that means that you put a pickup mic on the bad side and it transmits sound over to be heard in your better ear. It's not fantastic. Some people, I would say about half the time, maybe 60% of the time, people would find that useful and helpful and they would keep up with it. Sometimes people would try it and say, oh, it helps a little bit. They might not keep up with it. Um, from the ENT side of things, they sometimes can put a bone anchor into your ear and put a little vibrator on that's called a BAHA, or a bone anchored hearing aid. They sometimes do that for single-sided deafness so that the sound is then transmitted over to the better ear. So there's some technology that's done medically or surgically. But single-sided hearing loss is a problem because you look great most of the time and then you also struggle some of the time.
Mhm. Someone asked, what is the risk to long-term hearing loss from short-term exposure to loud noise? I'm thinking specifically of music concerts or Broadway-type musical performances where the sound is heavily amplified. This person got in the habit of carrying earplugs in case I needed them, but other times I forgot and had to choose between leaving the performance or experiencing actual auditory pain. And I wondered if these short-term experiences have long-term implications.
Okay. So noise, loud sounds, there's two pieces to that. There's the part where it's loud enough to actually possibly cause some temporary or permanent damage to our hearing. And then there's the other half of it, which is that we don't like it. We have a negative reaction to it. And one thing that happens, especially when there's some nerve type sensory neural hearing loss, is our comfort level for sound is actually a little bit restricted. So with a normal hearing person, you can go from soft, medium, loud, very loud, and have this wide range of soft to loud comfort. With a hearing loss, we often go from I don't hear it, I don't hear it, and now I'm just barely hearing it, and now it's too loud, and that gets very close together. So someone will often with a hearing loss is more sensitive to loud sound, to amplified sound, than somebody with normal hearing. And it's not so much that the hearing aid is overdriving them if they're wearing hearing aids, because hearing aids have lots of limiters built in to keep our ears safe and to not prevent um, increased hearing loss caused by the volume of the hearing aid. They have all kinds of limiters built in. It's really more our internal level of what we have now no longer find comfortable. So I don't think you're probably likely to damage your hearing further. If you're wearing hearing aids, you can turn them down and turn them off if the environment is so loud that you actually don't really need them in that environment. Don't lose them. Don't put them in your pocket. Put them away safely. But it's unlikely that it's going to cause more hearing loss. It's just that it's making you uncomfortable. Your ear is more sensitive than it used to be. And that's a big deal. I used to have people come in and say, my hearing's fine. I think it's too good. I cannot stand when people chew near me, or I'm really uncomfortable with hearing people um, chewing gum or making little noises. We're not really talking about hearing at that point. Most people do not have better than normal hearing, and testing would show their hearing was just regular normal. We're then talking really about a um, psychological or a perceived difficulty from sound. That's not really about having extra sensitive hearing.
Wonderful. Thank you so much. No other questions that I'm seeing in the chat, but that many people have expressed their gratitude and appreciation. Someone said that this was wildly informative and that you are superb, that this is so great. And I agree. I think that this is such helpful, useful, and important information for all of us as we age, and appreciate you sharing your time and expertise today.
Well, thank you so much for having me. I see a lot of familiar faces, and I'm happy if you catch me at the J to talk to you if you have a specific question. I didn't put up, but you could put in the chat perhaps, Shoshana. There's a website called heartracker.com, and they do some It's the word hear, the word tracker.com, and they do some reviews of new hearing aids, of over-the-counter devices. I think they're a pretty reliable source for comparing and contrasting different products if somebody's just wanting to get into it and have a look at it. Again,
Is
I'm
it
not an expert in over-the-counter devices, but they review some that look pretty
is
interesting.
it hearing tracker?
Just hear,
Hear
tracker.com,
tracker.
HEAR tracker. Uh-huh.
Okay, that didn't come up for some reason, but hearing tracker,
Oh, did I put it in wrong? I thought I had it. Let me look.
is it in the slides?
Nope.
No. Okay. I wonder if it's this. I'll put this in the chat and you can tell me if this
But you're
is
right. It's Hearing Tracker. My
okay.
mistake. Yeah, hearingtracker.com. Um, I don't have any affiliation to them. I did look at them a little bit when I was considering over the counter, uh, talking about over the counter devices, and I just see there's a lot of new stuff out there.
Hmm.
And keep in mind that trial period with any device, make sure that's very, very clear and spelled out to you, because I think that helps a lot of people take the leap when they otherwise might not quite feel ready.
Okay. Um, all right. Well, let's are there any other last questions? I'm just looking over the chat. One person said the person earlier who said that they you asked why they got tested in the first place, and they said they couldn't hear at a film festival. So it sounds like some issues with hearing. So um
Yeah, there are many theaters, you can give them your driver's license and get a hearing assistive device. A lot of theaters are required by the ADA to have assistive devices. So if you know that's an issue for you, you can ask for a closed captioning or a headset device in a lot of places. You may not always get it, but I think it's always important to ask, and it lets them know that people would like that technology. Um, I know DPAC in Durham, the theater in Durham offers headsets. And anytime you can get the sound right to your ears versus having it come through a big sound system, you're at a better chance of hearing and hearing clearly.
mhm. Any last questions for Patty? Someone says, I find the AVA app word tracker very useful.
Okay.
Do you know what that is?
I don't.
Okay.
Yeah, there's a lot online. There's all kinds of technology, and um, the more we can take advantage of it, the better.
Yes. Well, once again, thank you so much, Patty. I think we all agree that this is really useful, helpful, and important information. And I know I will be sharing this with some people in my life that will benefit from it. And I want to let everyone know that, of course, today's session is recorded. And oops, that's the hearing tracker. And I'm going to give you the list of the resources, the link to that now. It'll be up on our website, hopefully by next week. We hope that we will see many of you tomorrow for our final day of Aging and Thriving with Dr. Jonathan Fisher. He's in the Division of Palliative Care at Duke. His talk tomorrow is titled Advanced Care Planning, A Gift to Your Loved Ones. So that will be lovely to see many of you tomorrow to talk about those things. And thank you all for your engagement and your questions and your time today.
Thank you.
Thanks, Patty.